Now, moving on to median and ulnar nerve compressions, as the median, ulnar, and radial nerve are very important nerves because most of the arm, forearm, and hand muscles are mainly supplied with these three nerves. So, in this section, we'll be briefly going through the carpal tunnel and pronator syndrome, which is abnormality and median nerve compression. Then we'll also be going to the anterior interosseous nerve syndrome, what happens when the anterior interosseous nerve is compressed. And lastly, we'll be going through the cubital tunnel syndrome, which is the neuropathy of the ulnar nerve. So how the median nerve can be compressed? As you know, it actually descends as from the brachial plexus into the arm. Usually it does not give any supply, but at the level of the forearm, as it crosses the biceps epicondylus, it can split into a cutaneous branch as well as anterior interosseous nerve. The most common injury is usually at the level of the wrist joint, where it is lying between the nine tendons. There are four tendons of FDS, and then there are four tendons of FDP as well, and then there is a tendon of flexor pollicis longus as well. As it can, there is due to any injury, for example, Cooley's fracture, or there is edema or swelling associated with diabetes, or there is alcohol abuse. This could lead to increased intracompartmental pressure at the level of the wrist joint. And as it's a closed compartment and associated, there is inferiorly there is actually the proximal row of this, such as scaphoid, lunate, and bones, so they cannot expand. And on the flexor side, there is a flexor retinaculum. So therefore, being a closed compartment, once the pressure increases beyond a certain point, this leads to compression of the median nerve in the carpal tunnel, leading to carpal tunnel syndrome. So the other cause could be a proximal median nerve compression leading anterior interosseous nerve syndrome. When it gets compressed, just it leaving the elbow, it actually divides anterior interosseous nerve just distal to the bicipital epicondylus, where it can get entrapped and leading to a more proximal lesion. As it's told, it could be in form of anterior interosseous nerve syndrome. So now coming to the carpal tunnel syndromes, what are its clinical features? As you know that there could be pain and paresthesias in the radial 3.5 finger, mainly involving the thenar eminence, and this radial 3.5 fingers means thumb, index finger, and middle finger, and on the radial side of the ring finger. There is burning, pain, and tingling sensation as well. This could be altered sensation due to involvement of the median nerve. As the thenar muscles are mainly supplied, about 3 out of 4 muscles are mainly supplied with the median nerve, so they cannot, either there is paralysis or there is associated atrophy. Therefore, the functions of the thumb are severely compromised, which could, for example, writing, a pinch, a grip, this can be severely getting compromised, leading to clumsiness and weakness. Tunnel sign, if illustrated, that is actually percussion of the median nerve at the carpal tunnel. This can lead to kind of irritation of the nerve and recreation of the symptoms, especially associated with neuropathy. For example, the tingling, numbness, and paresthesias over 3.5 finger, and slow nerve conduction. There could be, as I told you, mainly the thenar muscles are supplied by the median nerve, so there is weakness of thumb abduction, especially because abductor pollicis brevis is compromised, and there is actually sensory neuropathy as well. There could be associated with cervical spondylosis as well, because the median nerve may be compressed due to there is associated cervical root contractment. Actually, the nerves which are arising from the cervical plexus, the injury could be higher up as well, and may be leading to double crush syndrome. That despite being relieved of the nerve over here, we still be having the same problem. Treatment includes, it could be initially it's NSAIDs and splints, but if it's then we can go for next step is the steroid injection. But if still the situation is not solved, and actually it's a long-standing case and leading to severe form of symptoms, then the endoscopic, there is carpal tunnel release, or then it could be open surgical release of the carpal tunnel, so that the pressure of the nerves is actually decompressed. The other form is another form of median neuropathy is called as pronator syndrome. This is most common in the weightlifters, especially who are lifting heavy weights with their forearms, because over the time, due to overuse of the muscle, there actually muscles hypertrophy and the forearm bulk increases, especially those who are doing exercise with pronation and supination with the weight in their hands. This As this nerve's median nerve descends from the exists from the elbow into the forearm, and there is actually bicipital aponeurosis which is attached to the radius with the form of a ligament of Stuthers. Now this ligaments can calcify due to hypertrophy as well, and this is where it actually impinges on the nerve, or it can lacerate the nerve at this area. And once this during this movement, especially during this excessive pronation supination of the movement, the nerve can get trapped between the two heads of the pronator arteries, and as a result this can lead to pronator syndrome, especially as I told you, associated with forearm pain and altered sensation, because this is the area which is actually supplied by the anterior trochleus nerve. Tinal sign may be positive, that is irritation of the nerve at the site of the compression can lead to recurrence and of a reappearance of the symptoms at the site. Fallon's test is actually negative. What happens with Fallon's test is actually done to for the carpal tunnel syndrome. The patient is asked to hyperflex its both wrist joint and keep it in this for 30 seconds. And at this, with this formation, actually there's a median nerve compression, the carpal tunnel. This would result in paresthesia, tingling, and numbness of the radial 3.5 fingers. But as the compression is not in the carpal tunnel, therefore the Fallon's test would be negative. But this, because the compression is more proximal, therefore the main symptoms will be in the forearm, not in the wrist joint. X-ray will usually, in case of if X-ray is done for AP and lateral view of the forearm, this will give a bony spur at the Stuthers ligament. Especially this ligament gets calcified and can injure the median nerve, leading to pronator syndrome. As you can appreciate it over here, that bicipital is attached in form of a ligament of Stuther which can actually compress the median nerve in the forearm. Treatment, usually have to do a surgical decompression. It's rarely solved with splints and use of steroids. Anterior trochleus nerve. Now this is one of the last median nerve neuropathies that, as we know, that median nerve descends from the forearm at the level of the elbow. It gives off in a branch, muscular branch form of anterior trochleus nerve. And this is actually, it's mainly the muscular branch, and the sensory supplied is actually from the median nerve itself. Usually it's a spontaneous physiological failure, mainly results in the motor weakness, and it's the most common weakness of the flexor pollicis longus and flexor digitorum profundus, especially the flexor digitorum profundus of the index and the middle finger is actually supplied with the median nerve, although the other two digits, the radial, ulnar, and it's actually supplied by the ulnar nerve. So mainly this results in the pinch function is mainly of the flexor pollicis longus and the flexor digitorum profundus of the index finger. But as these two muscles paralyze, therefore the most affected part is actually the pinch function of the thumb and the index finger. Therefore, usually when these patients are asked to make an OK sign with the two hands, they cannot make this OK sign because they cannot cause the contraction of FPL, that is flexor pollicis longus, and flexor digitorum profundus to form an OK sign and pinch their thumb with the index finger. Flex thumb tip can be seen, as you can appreciate it over here. Treatment is usually surgical exposure and release or tendon transfers. Usually, as it's actually getting caught between the bulkheads, therefore usually if once after 3 to 6 months we have to go for some kind of tendon transfer, that extensor compartment is transferred over the forearm so that flexion and pinch function can be restored. Now coming on to the ulnar nerve compression. Ulnar nerve, we know that can get contract at the level of the elbow, especially when it enters the arcade of Stuther, exits from the medial compartment and comes out on the elbow, and then just passes just below to the medial epicondyle. And there it enters into the cubital tunnel. Therefore, once it gets compressed over here, this results in a cubital tunnel syndrome. And as it descends down the forearm, it can also get compressed to the level of the wrist tunnel, where it enters into the Guyon's tunnel. And if it gets compressed at the wrist joint, this can lead to Guyon tunnel syndrome. Cubital syndrome is basically the compression of ulnar nerve in the cubital tunnel at the level of the elbow. And what are its clinical features? This include numbness and tingling of the mainly ulnar digits, that is 1.5 digit of the hand, weakness of grip and slight clawing. Usually the clawing is this, I will be discussing a term called as ulnar paradox when we'll be discussing the clawing due to the Guyon tunnel and cubital tunnel. There is intrinsic muscle wasting. Why? Because ulnar nerve is actually supplying all the umbilicals and interosseous of the hand. There is diminished sensibility over ulnar 1.5 finger. Froment sign is actually positive. This is classically symptoms which can be seen in the ulnar nerve. The patient is asked to hold a paper in the thumb and this, and if I have normal ulnar nerve, I have no abductor pollicis weakness, I will be able to hold it. But as the patient has adductor digiti minimi paralysis due to ulnar nerve neuropathy, so to hold this, it cannot adduct its thumb properly. As a result, when the examiner takes this paper out, the patient is to hold this back, it has to do like this and still unable to hold it. This is called as Froment sign, and it becomes positive in case of ulnar nerve injury. Then there is maybe a bone or soft tissue abnormalities because ulnar nerve can get entrapped in the arcade of suture. They can get entrapped with the medial epicondyle fractures, or there may be edema or iatrogenic injury to medial epicondyle procedures. Therefore, depending upon where it can get damaged, it can cause all these symptoms. And this compression could be due to simply a tourniquet being applied too low for forearm surgery at the level of the arm. There is a term called as ulnar paradox, that is that ulnar nerve injury usually results in clawing of hand. That is, there is hyperextension at the metacarpophalangeal joint and hyperflexion at the interphalangeal joints. This is called as clawing of the hand or intrinsic minus hand. But what happens is, as we know, in case of median nerve and radial nerve, higher the injury level is, the more severe will be the form of injury. But with ulnar nerve, it's actually paradoxical. What happens is that FDP of the ring finger and little finger is actually supplied by the ulnar nerve before entering into the cubital tunnel. Therefore, if this nerve is actually compressed in the Guyon canal, that is at the level of the wrist joint, it has already given the branches to FDPs of these two fingers. Therefore, this hyperflexion and clawing is actually decreased. There is sphere clawing of this two fingers, that is the index ring finger, but there is no clawing of this side. As a result, it appears that actually clinically it's less from severe injury, although the injury is higher up, and this would mean that neurologically it would be more severe form of injury. But in case of ulnar nerve, it's actually paradoxical to the other nerves we usually see. Treatment could be modification of the posture and splints. Splintage can be used before we can go for a surgery. Other options include is operative decompression. If we know the cause is at the cubital tunnel, we can do endoscopic or surgical release of the fascia, therefore nerve get decompressed. Other option is that if it is actually due to any malunited middle epicondyle or problem with the middle epicondylectomy can be done as well, so that ulnar can have enough space to move through the cubital tunnel. Another option is to anterior translate it above the medial epicondyle so that it actually does not get compressed in medial cubital tunnel. That is all done by surgical procedures. The release of roof of the cubital tunnel can be done either by, as I just told you, endoscopic or open surgical release. There can be anterior transposition of the subcutaneously, a submuscular plane, so that the nerve does not goes into the cubital, instead it goes anterior to the cubital and does not get compressed over there. In this section, we have briefly gone through the median nerve neuropathy and ulnar nerve neuropathy. We have seen three syndromes associated with the median nerve neuropathy, that is the carpal tunnel syndrome, pronator syndrome, and anterior interosseous nerve syndrome. We have also gone briefly through the cubital tunnel syndrome, which is associated with the clawing of the hand and ulnar nerve neuropathy. Keep watching sqadia.com. Thank you very much.